Good morning. Thank you everyone for being here. My name is Kristen Ryder. I am the current chair of the Department of Health Policy and Management, and I am delighted to be able to welcome all of our students, staff, faculty, alumni, parents, friends, and donors to the 2024 HPM Alumni Awards Ceremony. This is a joyous day for us when we get to recognize the accomplishments of all of our amazing students and all of the tireless work that they do all year, doing group projects and capstones and research papers and other things. So I'm very grateful to you all for being here. HPM is a community, and when students walk through our doors, they don't just join a degree program, they join that community. And all of you are part of that community and support them along their journeys. So we appreciate everything that you do. We have a full and packed agenda, so I don't want to take a lot of time, but I would like to at this time invite Mark Merrill, who is the chair of our Alumni Advisory Council, to the podium with me, where we have the great honor of presenting an award to this year's distinguished alumnus who will give a talk. So Mark, if you could please join me.
Thank you, Dr. Ryder, and good morning. I apologize in advance for the hoarseness of my throat. I have allergies, and I assured the chairman that I took a COVID test to make sure that it's not COVID. As Dr. Ryder mentioned, I'm currently the chair of the Alumni Council. I'm a 1984 graduate of the School of Public Health, Department of Health Administration, and had a wonderful 36-year career in healthcare management. So first, for the students, I congratulate you on your selection of an outstanding school. I wish the facilities were as nice when I was here. I think we had dirt floors here. We had an abacus to do our financial statement modeling. McGavran Hall was not even present when I was here as a student in 1984. But I had a wonderful cohort of colleagues. And as Dr. Ryder mentioned, I now have the honor of serving as chair of the Alumni Council. The Alumni Council is intended to accomplish a couple of things, and I hope that you all will be active as alumni. First, to have opportunities for the graduates to connect with the school, either by offering guest lectures, helping you find internships, residencies, jobs, networking, advice about areas that you might want to pursue. Secondarily, is to come to the school to talk to students, to be mentors and advisors. And then third, to help philanthropically so that we can provide support to students and faculty to offer aid, because we know that we compete with other schools. We know that we, UNC, compete with other schools. So to enhance the faculty and student support so you can make it more attractive to come to UNC. One of my colleagues who was on the original formation of this group is Ann Jacobs. Ann is here. There were 4 of us, along with Jeffrey Sims, who got this idea started about 4 years ago. We now have a council of about 26 people who literally spread from the West Coast to the East Coast, including Jamaica and off the coast in Jamaica. We have people in biomedical engineering, consulting, healthcare delivery, finance, government, public health, et cetera. So it's a great group of individuals who donate their time and efforts to support the school. So we also had the honor of selecting the Distinguished Alumni Award. So we had nominations that were submitted to the council. The council voted. We had 6 outstanding candidates who were nominated, all of whom are deserving to be distinguished alumni. But the council selected Lucy Savitz as this year's recipient. So I congratulate Lucy, a graduate of 94, on her award. So thank you for being here. And to the students, my encouragement is don't look at the title, look at the opportunities of what you're going to learn. I had a mentor early in my career. He said, don't look at just what the job title is, what the job does. Where will that job take you? And he advised me, I had this opportunity to head IT, managed care contracting, and risk management, 3 areas of which I knew nothing about. And he gave me the opportunity to head those areas. And it was career changing. To learn about IT. This is before electronic health records were so prevalent, as you can probably imagine. But insurance and risk management before capitated payments were very prevalent, and risk-based care and value-based purchasing. So whenever you have opportunities to explore, think about the skills that you will learn, the opportunities that will open up to you, and where that may get you in the future.
I am very honored to be able to formally introduce Dr. Lucy Savitz, who is a graduate of our PhD program. Dr. Savitz really embodies what our mission means to improve health for all. And as you listen to her biography, you will hear about a very remarkable and longstanding career as a leader really in transforming health systems and making sure that there's access to equitable, high quality, affordable care for everyone. So with that, let me introduce Dr. Lucy Savitz. Dr. Savitz has an MBA from the University of Denver and a PhD from our own Department of Health Policy and Administration at that time, now Health Policy and Management. Dr. Savitz has 40 years of experience in healthcare delivery and health services research. She's been newly appointed as a professor in the Department of Health Policy and Management at the University of Pittsburgh School of Public Health, where she also serves as senior advisor to the UPMC Health Plan Center for High Value Healthcare. Until August 2022, Dr. Savitz was Vice President for Health Research at Kaiser Permanente, Northwest Region, and Director for the Kaiser Permanente Center for Health Research based in Portland, Oregon. For 12 years prior to coming to Kaiser Permanente, she was Assistant Vice President for Delivery System Science in Intermountain Healthcare's Institute for Healthcare Delivery Research, where she was responsible for facilitating mission-critical health services research and enhancing the scientific stature of clinical investigators there. Dr. Savitz was an elected member of the Board of Directors for the High Value Healthcare Collaborative, overseeing the Discovery and Dissemination Board Committee, a group of 16 leading delivery systems across the U.S. committed to driving transformational change in healthcare delivery, quality, and payment reform. She's worked as an economist for the Colorado State Legislature, a financial planner at UNC Healthcare, a researcher in the Rural Health Research Program at the Cecil G. Shep Center for Health Services Research, which is close to my heart. That's also where I work. And a faculty member at the University of North Carolina, Chapel Hill School of Public Health. And finally, a senior health services researcher at RTI and Healthcare Quality and Outcomes Program. She's also been a senior associate at Apt Associates. She also worked with the Coastal Family Planning Health Center, a 24-site FQHC organization in Biloxi, Mississippi, to help provide technical assistance and support as they rebuilt after Hurricane Katrina. Her PhD minor was in medical geography, and she's applied this knowledge base in over half a dozen projects to assess resource allocation and spatial variations in service delivery, as well as examining neighborhood social risk factors. Dr. Savitz has led 4 projects specific to quality measurement for the Agency for Healthcare Research and Quality, and she served on several subsequent technical expert panels related to measurement for the agency, and many, many other projects. She's been acknowledged as an examiner for the 2001 and 2002 Malcolm Baldrige National Quality Program, administered by the National Institute for Standards and Technology in the U.S. Department of Commerce, and the American Society for Quality. She was faculty for the Institute of Healthcare Improvement, serving as on their Impacting Cost and Quality, Joint Replacement, and Episodic Bundled Payment Program and Patient-Reported Measurement Collaborative. At Academy Health, Dr. Savitz is currently the appointed board chair. She also serves on the Delivery System Science Fellowship Program Committee and is current and past chair of the Methods and Data Council and Committee on Advocacy for Public Policy. At AHRQ, she currently serves as an invited member of the subcommittee on the National Advisory Council. So as you can hear, many, many outstanding accomplishments. We are so pleased to have you here with us today. And with that, I would like to welcome Dr. Savitz.
Well, I should just take questions now. That's what happens when you get old. You have all of these different experiences. And this gave me an important opportunity to really sort of reflect on my career and what I wanted to share with you all, particularly the students in the room who are sort of just launching their particular careers. And I wanted to begin by saying thank you. Thank you for this acknowledgement. When I was a doctoral student here, the kind of research that I gravitated towards was not the kind that was really highly prized in the department. You know, most people became specialists in a very narrow area. And because I had always worked in policy and in practice, I had really an interest in thinking about how do we sort of take the tools and resources of research and apply them to the field to answer the problems of the field in a way that wasn't currently happening in our society. So these are my degrees. I have 2 degrees from the University of Denver. I have a PhD from this department, as has already been said. But the point here is that the degrees open doors for you. They give you the credentials to walk through a door. And so when I was a financial planner at UNC Healthcare, this was in the 1980s before there was a diagnosis for AIDS. And I was a financial planner, and we were looking at this influx of people who were relocating back to Chapel Hill. There were not sufficient resources to care for them in the community. This was before protease inhibitors. It was very complicated regimes of treatment for these people. And so thinking about how do we plan for this? And I think, you know, I was born a planner. Since I was 3 years old, I've been planning events and planning different activities. And it really bothered me that in healthcare delivery, everything was crisis management. And I worked with Carrie Kilpatrick, who was the chair of the department at the time. We did a national survey. We looked at the resources here in North Carolina, and it really set me on this path. Like, I mean, you could do research and help prepare for these problems. That seemed like it was a really useful opportunity for me. And so when I decided to have my second child and drop out of the workforce, I decided to get my PhD at the same time, which is temporary insanity, and I don't recommend it to anybody. But nevertheless, I did get my PhD from the department, and it set me off on a career that has been really rewarding for me in so many different ways. And so I'll share a couple of the highlights as I've thought about it. But again, the whole sort of notion here is, how do you apply the tools and resources and rigor of research to the problems that are facing the field? And there are numerous problems. And so there's numerous opportunities for any of you interested in this kind of a pathway to think about it. So the problem with healthcare delivery, and I could have said this even before the pandemic, it's doubly worse now. The US healthcare system is very complex. There are lots of problems, and we can't afford not to have evidence-based decision-making. It's just impossible. If I were teaching healthcare financial management today, I would tell you anything below a 3% operating margin is in the death zone for a healthcare system. Most health systems in our country right now are in the death zone, squarely in the death zone. In my own institution at UPMC, they laid off 11,000 people yesterday. You know, and we're seeing this happening across the country. And so, you know, there's increasing pressure to do more with less in our society and in the healthcare systems. We're putting responsibilities on the healthcare systems that they're ill prepared to really carry out, I think, in an equitable way across our country. I personally think it's a failure of American healthcare policy. We're asking the healthcare sector to address social needs. There was a book that was written in 2016, The American Healthcare Paradox. If you've never read it, I really highly recommend it. And what they did, it's usually alleged that the US spends twice as much as other OECD countries. And so they combine social welfare spending, public health spending, and medical care or sick care spending. It's not true that we spend twice as much. We're middle of the pack. What we do differently is we disproportionately invest in sick care at the expense of social welfare and public health. And we saw this very clearly during the pandemic. And so for us to think about this, you know, why is a healthcare system? I remember going around and talking to accountable care organizations, and they said, we need to deal with the homeless problem. And I said, why would you do that? You know nothing about how to deal with the homeless problem. There are organizations in your communities that do. How do you partner with those organizations and help support them in ways that you can have meaningful change? And having worked in Biloxi, Mississippi, I can tell you the hospital system in Biloxi, Mississippi is nowhere near ready to help with some of these social problems in their community as we are here in Chapel Hill or in Pittsburgh, Pennsylvania, where I come from. And then this whole notion of how do we shift the way we think about delivering care in our society as we move to value-based purchasing. This has been a march that started long before the pandemic, but for us to understand how do we sort of engage and proactively care for people in a preventative healthcare way is really important. And then just the lack of evidence to base organizational and operational decisions on. There was a study that was done in Canada, and they surveyed healthcare administrators and followed them over time. And what they found was that healthcare administrators had evidence to base their decisions on 25% of the time. That meant that 75% of the time they have absolutely no evidence. They were just shooting from the hip. And some of us are more prepared to do that than others. So for those of us who've been working in this sort of field of embedded research, this is not new. You know, people hear about the learning healthcare system. You know, LHS is sort of a term that's sort of bandied about. But there were 3 reports that were done by the Institute of Medicine in 2001. One was Tara's Human that first told people about all the harm that was being done by our healthcare delivery system. And let me tell you, we haven't gotten a whole lot better. The second report was the one that is illustrated on this particular slide, Crossing the Quality Chasm. And the third was Envisioning a National Healthcare Quality Report. In the second report, Crossing the Quality Chasm, they talked about this virtual cycle of how could you use the data that was being generated by the care that was being provided to continuously improve the healthcare delivery system. So that was sort of the vision that was laid out there. And a lot of people, including myself, have worked tirelessly over the last couple decades trying to make this a reality. And I could talk for a very long time about all of the issues that we've encountered and some of the wins that we've made. So in 2012, after a series of roundtables by the Institute of Medicine, now the National Academy of Medicine, they came up with this definition of what is learning health system. What is a learning health system? And I can tell you, if you go to any healthcare system in this country almost, they'll all tell you that they're a learning health system. And I've been quoted as saying, if you've seen one learning health system, you've seen one learning health system. That's often said about EHRs, but it's very true. And so there are a group of us who've been working nationally over the last 5 years to come up with a maturity model that'll serve as a roadmap for people and a self-assessment tool to help guide them in how do they mature their healthcare delivery system to realize that virtuous cycle. So I would advocate, and this is an old slide, I've given this talk with this slide in it hundreds of times. We require a sustainable system that gets the right care to the right person at the right time and then captures the results for making improvements and knowing what works. And that's the whole key. How do we know what works? We know that in our healthcare delivery system, and there are varying estimates, depending on how you do the math, between 30 and 70% of the care that we're providing is wasted dollars. So when we think about the challenges of where do we get the money to do this or that, there is money on the table that could be had. And it's how do we sort of make the case for those reallocations of those resources. We also know from studies that have been done by Beth McGlynn and Rita Mangione-Smith that less than 50% of the preventable care that we know does work gets actually delivered to both adults and children in our country. So when we think about it, the opportunity is there. This is a sort of reconfiguration of the virtuous cycle that you saw in the earlier slide from Crossing the Quality Chasm. And it was in a report that was published by a good colleague of mine, Jean Marie Gies, Chuck Friedman, who is the chair of the Learning Health System Department at the School of Medicine at the University of Michigan, and myself. And the whole idea here is to understand how do health systems get evidence and incorporate that evidence into the work that they're doing. And so there's a reality that they get some evidence from external sources, from the peer-reviewed literature, which will always be a gold standard for us. And so as health services researchers, you know, that's our bread and butter. How many publications have you had, kind of thing. But the notion of how do you generate this evidence within the healthcare system presents certain challenges because people who work in healthcare systems are not incentivized to publish their research. And I can tell you over the years, one of the biggest battles I've fought is how do we find a place in the peer-reviewed literature to publish this research? It was very hard and very difficult for many, many years. And I'll talk to you about a couple examples where there were investments made But, you know, more recently, I was at a meeting at the National Academy of Medicine with all the main journal editors. And I was listening to them talk. And I wrote down on a piece of paper the word distrust, and I put a square around it. And their issue was that you can't trust EHR data to do health services research. And I said, are you serious? You think claims data are okay? You know, for those of us who've worked with claims data, there are lots of problems. And we've developed methods and techniques to address the shortcomings of claims data, which was, you know, the predominant data that was available to us. EHR data takes us closer to real time as an artifact of the care that's being provided. And we published a paper that actually points to a lot of the methods that are being developed to address the shortcomings and problems of EHR data. But remember, claims data is used to optimize billing. EHR data is intended to optimize care delivery. So neither are intended for health services research purposes. Both have shortcomings. And so it's our charge to think about how do we better use the data that's available to us to answer these problems that are happening. So I feel like I've been on this journey to Oz. And I feel like I'm quickly arriving at the journey to Oz, not just because I may be retiring in the next couple of years, but I've seen numerous investments in the learning health system journey. And I just want to point them out to you because they're both public and private in nature. So I was very fortunate to be at UNC, Chapel Hill, during my doctoral program, and then soon after I graduated. And there was a group co-led by Steve Shortell and Howard Zuckerman, the Center for Organized Delivery Systems and the Center for Health Management Research. And they brought together a consortium of 8 delivery systems who invested in research. So they saw the future and they said, let's see if some of our problems that we share could be answered by research. So 2 of my first studies were actually published there. And I'm still quoting them. In 2001, ARC launched something called the Integrated Delivery System Research Network. And so this was, and you'll see sort of how these different investments shape the way we're thinking about building the workforce. So in 2001 with IDSRN, what they did was they made the awards to researchers who had research partners in health systems, which is a different dynamic in terms of who's in the lead. If you think about it, I funded at least 17 different projects under that initiative. One of them was Intermountain Healthcare, where I ended up working and getting a job later in life. In 2009, Hal Luft and I co-founded the Delivery System Science Fellowship Award at Academy Health. And that notion was, could we bring a fellow into a health system as a researcher for 1 to 2 years and see, are they a cultural fit? Do they like doing this kind of work? Do they understand how to talk to us? And that's one of the biggest barriers when you plop a researcher down into a healthcare system. You know, can they speak our language? And then in 2010, ARC funded the Electronic Data Methods Forum. And there was the first place that we found a journal. We founded the journal so that we could publish this kind of research in the peer-reviewed literature. It was called eGEMS. So there were a number of projects that began to be shared on a different sort of scale because they couldn't get published in the peer-reviewed literature. And then in 2013, under the ARA funds, ARC funded a research training program in patient-centered outcomes research and comparative effectiveness research. And so that was one of the first major national initiatives where we invested in training the workforce. So the people who would go out and work in these healthcare settings. And then it was quickly followed by the ARC PCORI Learning Health System K-12 Award. There were 11 of those made across our country. There was the VA Advanced Fellowship more recently in 2022. And then lastly, the ARC PCORI E-STAR Centers. The shift here has been with the E-STAR centers, the money goes to the health systems, and then they bring the scholars into their organization. So the health system is really setting what's the research agenda? What are the problems that you need to have answered? And so it's a different dynamic that I think has a really demonstrable impact on the way the work will be done as we move into the future. There also have been private investments. So in my introduction, it was noted that I was on the board of directors for the High Value Healthcare Collaborative. This was a collaborative that was alive and functioning under the membership dues of 16 delivery systems in the United States from 2009 until 2017. And basically they came together as a collaborative to say, during healthcare reform, let the health systems have a voice in policy. You know, don't make changes to the healthcare delivery system in terms of how we organize, how we pay for care without us having a say in that. And so that was really the main principle that brought people together. But then there were other two reasons that we came together. How could we bring the data together in a way that allowed us to have shovel-ready data? Some questions can't be answered by a single system. They need a large amount of data so that you can answer those questions. And so we created something that's called a data trust. So when you bring data together, there are two main ways. One is a federated system where everybody holds their own data, but there's a common data standard. The other is a data trust where you bring all of the data together. We brought claims data, EHR data, administrative data, et cetera, together. And you know, there are a lot of legal issues, a lot of privacy concerns that we dealt with in that process. And we have a paper that we talked through all of those kinds of issues. But the notion here was, how could we address issues and understand and deliver the evidence that's needed at the point of care? The best example of this was implementation of the 3-hour sepsis bundle. So when we were implementing the 3-hour sepsis bundle across all these different systems, and this was a cross section of the industry. It was not all Mayo clinics and Intermountains. This included Denver Health, which is a public health authority in the city and county of Denver, a critical care access hospital. So a whole cross section of the industry. And we looked at the data and it looked like most of the health systems, even leading health systems, were not complying with the 3-hour sepsis bundle. You may or may not know that sepsis is the leading cause of in-hospital mortality in our country. And so it was really important for us to go out into the field and figure out what's going on. And I was trained in a heavily quantitative department here. I remember very clearly 42 credit hours of quantitative methods to get through this program. What I was never trained in was qualitative research, and had to sort of, go through and self-train and all those sorts of things. But when we went out into the delivery systems and found out what's going on, the 3-hour sepsis bundle was an all-in measure. So you had to be doing all 5 elements of the bundle or you got no credit with the federal government. And when we talked to the doctors, especially in Hawaii, they said, we don't want to harm our patients. And we're like, what are you talking about? This is to prevent sepsis. And they said, most of our patients are over 600 pounds. And the fluid bolus that you have to push in this very short time period is based on the patient's weight. And many of our patients have end-stage renal disease and congestive heart failure. We're afraid if we push that fluid bolus, we will harm our patients. So it wasn't out of, the fact that they didn't want to implement or they had too many other things going on in their practice. It was because they were afraid they would harm their patients. So we were able to go back because we had the data, run the data, provide the evidence across the systems and show them, no, in fact, you would not harm your patients. And so we saw bundle compliance skyrocket, which was a really amazing opportunity. I don't want to bore you with a lot of the things that I could tell you stories about many of the different projects I've worked on. I'm happy to engage with people. You have my email address, and I really consider mentoring and helping others to be an important part of my career at this point in time. But I am the chair of Academy Health of their board. And so if you want to learn more about learning health systems and learning health system science as it's being sort of promulgated across our country, I co-lead the Learning Health Science Interest Group with Hal Luft. We're going to be meeting at the ARM, the annual research meeting on July 1st. The LHS Maturity Model Group will meet on July 1st as well. And then we have forged a relationship with the Learning Health System Journal. So it's the official journal of the LHS Interest Group. Any Academy Health member gets a 15% discount on the APC fee. So again, this was an opportunity to reflect. And what I'd like to leave you with as I sort of reflect back over the experiences I've had, the many, many incredible colleagues I've had over the years, people I see here in the room here today, build, grow, and maintain your relationships. It takes time to spend with people, to reconnect with people, to stay in touch. As part of the Learning Health System K-12 award that I co-lead, I've had a Learning Health System leader group where I've called upon my friends from over the years to come in and give talks. And one of them said the one day, when Lucy calls, I always pick up the phone. You know, maintaining those relationships, building those relationships with people that will carry you across your career are incredibly important. Honor the commitment to service of our community. I just guest edited a special issue of the LHS Journal. It was like pulling teeth to get people to review articles. And I'm like, what has happened to our research community? You know, if you want your papers to be reviewed, if you want your grants to be reviewed in a thoughtful way, we all need to stand ready to participate in that process. It's not paid service. This is like a donation that we do in evenings and weekends. I'm leaving here to get ready to co-chair a VA coin study section. You know, I've got 20 some proposals I've got to review. This is an opportunity for us to honor our commitment to our community and then pay it forward through mentoring and training. I'm going to see one of my lifelong mentors, Arnie Kaluzny, after this. Arnie and I talk on a monthly basis to this day, and I left the program in 1994. And then my children would laugh hysterically if they heard me talk about number 4. Strive for work-life balance over a lifetime. My point is that at any single point in your life, you may not have work-life balance. But if you think about it in cycles over time, you know, when my kids were little, they went to Estes Hills Elementary. I lived in Lake Forest. I took a job at the Shep Center so that I could be close to my kids. If they needed me, I could drop them off at school. I could pick them up after school. You know, at different points in your life, you'll sort of slow things down, slow your roll so you can do what you need to do. Now that my children are grown, off doing their own thing, I can work as much as I want or as little as I want. So strive for some work-life balance that makes sense, and don't forget your kids. That's an experience that will never come back again. And then make a path for the next generation. I've done a lot of work with HRQ, with Academy Health, that's really been about how do we make sure that there's research funding for health services research for the next generation as we go forward. And I think that's a commitment that we all need to make. You know, we're all citizens, we're all taxpayers. Write your Congress people. There are important opportunities to ensure the funding gets where it needs to be. And then I would just say the journey's been the reward. It's been an incredible ride. I've given you some selected publications. I've sort of sorted them out by training programs and by different kinds of initiatives. And again, thank you for this incredible honor and the opportunity to come home to Chapel Hill. So thank you very much.
We do have a little bit of time left, so I would like to invite Dr. Savitz back to the podium. We didn't have time for Q&A at the beginning because we weren't sure how long things will take, but given her breadth of experience and her amazing talk, I want to give a little time for all of you to ask her questions and be in dialogue about her work and questions you might have. So thank you, Dr.
Thank
Savitz.
you. Any questions?
I have a question.
Sure, Mark.
I spent my career on the delivery side. Forming a connection with getting the outcomes research has always been a particular challenge, even though we've gone to electronic health record. I don't know how you penetrated that barrier to get health systems to collaborate on getting outcomes. Like your sepsis bundle was a perfect example.
Yeah. Well, I think part of it is that I worked in a health system before I came back and got my PhD. So I knew how to speak to them. You know, so I had people coming to me making cases for different kinds of things, like we should do this or we should do that, but they could never sort of penetrate it in a way that made sense to me as a financial planner. So having that language capability and all the work we do in sort of the advanced pre and postdoctoral training in learning health system sciences, teaching people how to communicate. how to use the language, how to ask the questions that are the questions. I mean, I don't have to say this in a school of public health. You know, you guys have the, you know, the tabs on CBPR or community-based participatory research. It's how do you work with the people in the health systems to answer the questions they have, not the questions you have as a researcher. And so I think it's those trusting relationships that sort of opened the doors and kept them open for me. Thank you for that question.
I want to take
Sure, Kristen.
So I'm an accountant and I teach accounting, and we were talking earlier. I think, you know, the health system in the US is, as you said, very complex and somewhat driven by the market. So how do learning health systems keep their eyes on the patient in their aspirations and balance that with kind of the realities of trying to maintain an operating margin?
Yeah, you know, it's some of my more recent work has been around age-friendly healthcare for obvious reasons, since I'll be one of those people. But I've done a lot of work with people with multiple chronic conditions, and as researchers, we've used these pejorative terms because we've talked about people with multiple chronic conditions as being sort of the high utilizers, which I think is a terrible term to use for people. And so the big challenge of the healthcare system, because we know like 5% of the resources are taken up by this very small group of people, or the majority of the resources are taken up by this very small percentage of patients that are seen in our healthcare delivery system. And so for us to think about how do we sort of provide those services to those individuals in a way that, if you think about an iceberg, you know, you see the tip of the iceberg. How do you keep the people with rising risk from accelerating into that process? And so that's really been the focus. And it's not just the focus here. You know, a lot of this work has become global. So the UK, Japan, Germany are well ahead of us in terms of the population dynamics of an age society. And so there's a lot we can learn from those countries, and we have learned from those countries, and hopefully can sort of use them to enact the kinds of programs that make sense. Like in Japan, you can pay an extra, very small fee to your postman. And so, like, for instance, I just moved back to Pittsburgh to help care for my aging mother. When I lived in Portland, Oregon, it was hard to keep tabs on her. If I could have paid my postman, you know, $2 a month to just stop in and say, how's Nancy doing today? You know, does it look like she had her med? Did she eat breakfast, kind of thing? And they report to you. There are other cities that have done remarkable challenges and opportunities to think about how do we reconfigure what's health and what's healthcare, and the understanding that they're not the same thing. Yeah, so the question is about the large layoffs that I noted for UPMC health system. It happened yesterday, so I don't know the answer to your question. What's the impact of it? I do know that a lot of times, when I was at Kaiser, we had a major reduction in force, or RIF, that, you know, everybody was given targets. When health systems do those major layoffs, they try to refrain, obviously for, you know, the obvious reasons, not to go directly to patient care services, to go to administrative services or non-patient facing services, to think about how do you sort of sustain those cuts. Because right now, I just led a task force for the federal government last fall. One of the biggest issues is the healthcare shortage that we're facing. And so, you know, it cuts across all kinds of care delivery personnel. It's not just physicians, it's not just nurses. And I don't know what's going to happen. And it hit both the health plan and the healthcare delivery system. So stay tuned. Yes, sir.
Thank you so much for coming. My name is Jacob Barnes, MBA MHS student. My question is, I really like when you talked about making decisions based on data. And I know this is very an important aspect of healthcare delivery. So do you see artificial intelligence, AI, playing a role in this field? Because I know one of the main problems is most healthcare administrators don't have the skills to analyze this data.
Yeah. So when you think, we're all learning about AI in real time, you know, and anything I say today will probably be different tomorrow. So with that in mind, when you think about AI, there are really three buckets. One is robotics, and we've had robotics for a long time. The second is really around sort of large learning models or predictive analytics. We've also had those for a very long time. What's newer is the generative AI. And the jury's still out on a lot of this. You know, a lot of what we're learning in the New York Times and the Wall Street Journal, to be quite honest with you, because we can't keep pace with, you know, in the peer-reviewed literature. But understanding what I've seen is the AI assistance, because that's really sort of the main role right now. How do you take routine processes and procedures and, you know, let a computer do it? So reading scans, for example, taking notes as a medical scribe, you know, those kinds of things. There's still a lot of problems and there's still a lot of hallucinations that occur in the data. I was on a call with a colleague of mine and he said, look at this paper. He said, I'm a co-author on it. I've never written this paper. It says it's published in the New England Journal of Medicine. I mean, so there's a lot of like fictitious stuff that's coming up there. And so I think we need to be scrupulous users of the tool, but willing to investigate and analyze how they're performing relative to humans and what's the role of humans in that process. And I know the gentleman back there had a question. Oh, sorry.
What's really coming out right now is using AI for diagnosis and pathology and radiology.
Right, those are the scan things.
They're picking up cancerous cells in pathological specimens than pathologists.
The problem is reimbursement. You know, so we don't always reimburse. You know, so you could have the privilege, if you have money, to pay for those scans to be read by AI. So we need to keep pace with the change. Sir, you had a question. Sorry
about that. Dr. Savitz, as PACE moves towards a fee-for-service model from capitated, what are you thinking about that as we move away from this idea of like just paying for the care overall and then moving away from that?
I'm not sure I'm familiar with the program that you're talking about.
It's the program for advanced aging.
Aging, yeah. And they're moving to fee-for-service?
What's that? Program for all-inclusive care of the elderly.
Yeah,
moving from a capitated model to fee-for-service, and I'm just curious what your thoughts are on that.
You know, I've worked in healthcare delivery systems since like the mid-1980s, and so I've been through the whole sort of trajectory of different payment models and different kinds of things like that. I'm not sure that we have the right answer to what is the right payment model, because there are incentives and disincentives with each of the payment models that's before us, whether it's fee for service or whether it's, you know, sort of capitated care. So I could spend a whole afternoon talking to you about those kinds of things. But what I can say is that when we look at other countries and what other countries have been able to do with a global health system, I think that's the direction we ultimately need to figure out how to get into. And we'll sort of dink around at the margins on these different kinds of things. And, you know, if it's a fee-for-service model, is it going to include all of the services that those people need? Because a lot of the elderly people need things that are beyond what you'd consider health care. There are things that let them stay living and active in their communities. And so we haven't done a really good job of figuring out how to pay for those things. And I don't know this program, so I don't know whether or not they're talking about those kinds of issues. And that would be my main concern. Thank you. Any other questions? Yes, again.
So you've been kind of doing research out in the real world, I would say, right? Day to day. Yeah.
I like to think so.
And so I guess, you know, coming from an academic institution where, you know, as you said, the gold standard peer-reviewed literature, and being able to take those health services research methodologies to create imperfect results, but better than the 75%, you know, swag. Can you talk a little bit about how you're able to use more recent data, imperfect data, decision making?
First of all, I wouldn't say the data is imperfect. I think it's a new kind of data for people, and you need to learn the new methods and procedures for using that data if you can get access to it. I mean, as I look around the country at different delivery systems, some are more open and accommodating to researchers using their data. I can tell you at Pitt, I never thought I'd even have to ask because I worked at Intermountain, I worked at Kaiser, I could get any data I needed within the provisions of privacy and security standards. At Pitt, it's like this political war. The health system holds its data, the health plan holds its data, and they're the same organization. And then if you're a researcher at the university, forget about it. So I think, when we think about what's a mature health system, do they make the data available to do the work is the king. It's not inferior. And the fact that it's been hard to get this kind of research published is not because the research is less rigorous or inferior. It's because it's using a different data source. It's the data source that the journal editors have objected to. And they've not had credence with the data because it's newer. It's more newly available to people. And so I think educating them. So after that NAM meeting that I told you about, I worked with the editors at the Journal of General Internal Medicine, and then I co-edited a special issue of their journal with Christian Helfrich, who's also a graduate of this department. It was one of my doctoral advisees when I was here. And they created a section in the journal to publish peer-reviewed literature. The other problem is people who work in health systems, they don't have an incentive to publish the same way. If they did, they'd do it at night and on the weekends, which, many of us who are researchers do our work like that on nights and in the weekends too, but there's no incentive for them for promotion or anything like that. And so it's getting accustomed to looking at that data, knowing how to analyze that data. And my son, who's also a graduate of this department, Sam Savitz, he works at the Mayo Clinic. He's an embedded researcher. And so some health systems, like the Mayo Clinic, actually pride themselves in having their investigators publish, but most health systems do not. Good question.
Got a question online that seems related. It says, what can we do to improve EMR, EHR data to support answering scientific questions better?
Well, I have 2 publications on that topic. Google me or send me an email and I'll provide the information. The problem is that what the data architecture is that underlies this, and Chuck Friedman talks about a socio-technical data architecture, but I described to you what a federated system is. Everybody holds their own data, but there's a common data structure, and then there's a data trust where everybody brings their data together. It's enabling those kinds of commons that come together to create the data. The Healthcare System Research Network is another network I've worked with. They're a federated system. And that's 19 health systems around the country that bring their data together to answer these kinds of real world problems. So, good question though. Anybody else? Yes, ma'am.
Following up the previous question on it's still on time like the peer review publications, you think that'll data be open to the idea of talking directly to the public through magazines, news articles, media outlets, reporters, going on the radio.
Yeah.
I think only looked at our journals that are own field.
Yeah.
I'm so surprised that if you talk about the work of people, they actually have more insight and some that she's than we do. So I don't know, do you think academia gives that?
Well, I have a very pointed opinion on this question. So what I can tell you is that we should. The distrust of science in our society today is a huge problem. And I think everything that we can do to communicate effectively, to speak the language of people who need to know and give them interpretable information they can use to make informed decisions in their own health and the health of their family members is critically important. I just spent the last 8 months helping to recruit the new president of Academy Health. And I'm incredibly proud to tell you that Aaron Carroll was selected as the new president. If you don't know Aaron Carroll, he has a blog with Austin Frank on The Incidental Economist. He writes for the New York Times and has for many, many years on very complex topics. And so we're really pleased to have Dr. Carroll working with us to think about, and I would challenge departments like health policy to think about how do we measure impact of our work? Peer review publication will always be important, but How do we communicate and make impact on policy, on guidelines that are being set, on the communities that we serve? I think we need measures of impact that will allow us to address that. Great question. Anybody else? Yes, sir.
Seem to be inviting a question about work-life balance with some of the things. You know, a lot of us have things in our lives that we're defining events, and I wonder if there are one or two that you might share with the group.
Defining events. Well, I shared one with you, was when we were working with the AIDS population coming back, and the health system was doing nothing to prepare at that time. And yet we were getting all of this information about the needs of the population here in North Carolina. So that, I think, was something that was very pivotal to me, that I could actually help answer questions and prepare for things like an age-friendly health system. For example, there's this tsunami coming and none of us are prepared. So I think I'd have to say, you know, just personally, the experiences I've had interfacing with the healthcare delivery system have been really important for me to sort of keep me motivated to go on. I've had family members that have had very critical illnesses. I've been doing quality improvement and patient safety for 3 decades. I sat in the hospital with a family member and I said, I can count 8 adverse events that are about to take place here right now. You know, and if you have to be a researcher who knows patient safety and you tell anybody that you talk to who needs healthcare, do not get admitted to a hospital without somebody sitting by your side the entire time. That's an important message. And it means there is a lot of work for us to do. We just published a commentary where we looked at what's happened to patient safety after the pandemic. It's gotten a lot worse. The federal government now has an initiative on patient safety and workforce safety, because the other problem that nobody's talked about is workforce safety. Huge problems in violence in the workplace for healthcare workers. So if we think about the shortage in healthcare workers, who wants to go there if you have to worry about somebody not just psychologically abusing you, but physically abusing you in practice? These are major issues that we have to think about as a society. So I've never learned how to have work-life balance, by the way. Just FYI. Yeah.
Each one handles the intrusions that the other has been my attitude.
That's probably very well put. Thank you. Any other questions? Okay, great.
All right.
Thank you very much.
Yep.